Polycystic ovarian syndrome, or PCOS, is a common but treatable condition. Stay tuned to learn how you can manage it with our guest, Dr. Efrat LaMandre.
You're listening to Live Foreverish, a show dedicated to helping you live just a little longer. Here's your hosts, Dr. Mike and Dr. Crystal Gossard.
All right, welcome to Live Foreverish. Dr. Crystal, I'm happy that we're talking about this with Dr. E. She's, I think, the perfect guest for the topic of PCOS. Just so the audience knows, she's a return guest. Her name is Dr. Efrat LaMandre. She goes by Dr. E. She's the founder of the new method where she empowers patients to finally realize that their symptoms are not in their head. That's a good thing. We like that. She helps people optimize their health, prevent illness, reduce medication use. I like that too. And feel great by getting to the root cause of their illnesses. She wrote a book, It's Not in Your Head. Your body doesn't feel right, but you don't know why. In addition, she owns a primary care practice called EG Healthcare, a medical scribe company called HawkScribes, and an educational company, EG Prep. Dr. E, welcome to the show. And I think I already told you this before. You make me feel like a slacker. you got a lot in that bio.
I get bored easily, I guess. So.
Well, welcome back. We're so happy that you could join us today.
Thank you.
So PCOS, I think for me, I'd love for you to kind of, for our audience, tell us how you describe this to your patients.
Okay. That's a great one because so many patients come into either my primary care practice or functional and they're devastated, right? They come in and they just went to their GYN and they got this diagnosis PCOS and they're handed sometimes 2 or 3 medications and they come in like, I have a disease. Mm-hmm. I need to be medicated for it. And what do I do now? Like, what happened to me? How did this happen to me? And what I find happens a lot is that no one actually explains what it is. And so you feel like it's this other thing that just happens to you. It's a very disempowering diagnosis, the way it's delivered most often, I should say.
Yes, I know. My MD people, they're not always great at describing things and delivering the message. I know.
So I explained to them, I said, it's not like this other disease that's happening. It's really, and it's not even a GYN problem. Like, it's great that you're a gynecologist and you probably went there maybe because your period was off, but it's actually not a GYN problem. Just like psoriasis is not really a skin problem. It's a system problem and it's an insulin problem. I don't know if you want me to jump into that right now, but that's the beginning of the conversation. And the point is to empower them to have control over it.
Right. Yeah. I like that. I like, you using the analogy of, psoriasis and stuff like that, it's more of a systemic thing going on, right? I think that's a good foundation to start, right? Educating them on but how often do you see this in your practice?
Every day. Every day in my primary care practice, people are coming in for annual visits. And so it's like, hey, are you up to date with your GYN? Sure, I'm up to date with your GYN. Oh, and by the way, I was diagnosed with PCOS, right? So it happens every day. They may not come to my functional practice with PCOS, but in primary care, it's happening every single day because for so many people, they're going to their GYN because their period's off, they have acne, right? They have, hair in places that they want. But it's estimated that about 5 to 10% of women are affected by this. So it's significant, which is why I'm seeing it every day.
Yeah.
And the other thing is, right, it's a syndrome. It's a spectrum. It's not this one thing. So you could fall anywhere on the spectrum. So the spectrum has a lot of symptoms, from irregular periods to facial hair difficulty, losing weight, thinning hair in the areas that we want hair, too much hair in areas that we don't want. And you can have...
That sounds like me. Hold on. Wait a second. It's kind of what I'm going through.
Wrong sex. So.
It also kind of sounds like perimenopause and menopausal symptoms. So I'm just wondering, what is that? What does the diagnostic process look like?
That's a great question. Well, perimenopause, sure, but this tends to usually diagnose a little bit earlier than that age group. But so the process, and now because it's a syndrome, it also, and because it's a spectrum, the diagnosis is a little difficult because so there's two, blood work is done and an ultrasound is done. But so you could have a positive ultrasound. Let me explain a little bit about what PCOS is. And then if you don't mind, I can go back to the testing, because then you can see why the testing is so confusing, right? Mm-hmm. So PCOS is this insulin problem. You have this elevated insulin, and we could talk about why that happens in a moment. But one of the things that the insulin does is it tells your ovaries to release more testosterone. Testosterone is great for women. We need testosterone, but we don't need too much testosterone. So now you have this extra testosterone circulating. And what that does is messes up your ability to ovulate, to create eggs. And so those eggs can suddenly become cysts. So you can have a lot of undeveloped eggs. Those are called cysts. And that's where the name polycystic ovarian syndrome comes from. But you don't have to have those cysts to be diagnosed, right? Mm-hmm. So you may have an ultrasound that shows that your ovaries have a lot of cysts because you've had this testosterone going on for so long. But you may have a completely normal ultrasound because maybe your testosterone is not that elevated, or hasn't done that, but it's doing other things for you. So even with a normal ultrasound, you can be diagnosed with PCOS. Sometimes your testosterone shows up elevated in blood work, but sometimes it's symptoms. Hey, my periods are not regular. I have acne. I have hair here. This is thinning. And even if your tests are normal, you can be diagnosed with that. So that makes diagnosing it even trickier.
Right. Yes.
Since we're talking about hormones, though, where does progesterone play a role too? Because if you have a lot of testosterone and you're stopping ovulation, and those are what can become the cyst and stuff, isn't progesterone also going to drop, because most of the progesterone comes from releasing the egg, and if you don't fertilize it, that leftover, it's called a corpus luteum, whatever, but that's where a lot of progesterone comes from. So is that part of this as well?
It is part of it. The link is not as direct. It is more of like a downstream problem. So now we have this ovulation problem, and so yes, now we have this progesterone problem, and yes, that's part of it. But it's almost like, so many people will come in and say, can you test me for my hormones? So let's just say, even if there is a fluctuation in hormones, it's not that we suddenly need to give you more progesterone, right? That's not the answer. The answer is, why did this happen upstream? Yeah, what happened to cause this elevated testosterone, messed up ovulation, lower progesterone?
Okay.
So it can happen, but it's not a root cause analysis.
Right. And so you started off by describing you have the insulin, and then the insulin is talking to the ovaries. How does that start? Let's go all the way back to the top.
Okay. This is actually my favorite metaphor, because I'm like the person who creates metaphors for my patients. So every time you eat something, almost all of it becomes a form of glucose. So now this glucose is in your body, and it needs to get into your cell. So I want you to imagine that insulin is like Uber. It picks up the glucose and it transports it to the cell. And if all goes right, it drops off its passenger at the cell, and the cell says, thank you so much. That's great. And that is called insulin sensitive. I love insulin. Thank you for everything you bring me. But we eat another slice of pizza, another sandwich, and now we have a lot of glucose and a lot of insulin running around. They're trying to transport it to the cell, and the cells are like, nah, dude, I'm good. Yeah. I am full. I don't want any more. Yeah. And so the body's first response, because now we have a lot of passengers, the body's first response is to create more insulin, because it's thinking, oh, probably I need more insulin. It's trying to compensate. So we have what's called hyperinsulinemia, right? You have too much insulin. And this insulin, they all have passengers, and they're all trying to put it into the cell. The cell does not want it. That argument is called insulin resistance. Mm-hmm. So now we have all this insulin running around, all this glucose running around, and it's going to start having effects on us. So the insulin tries really hard. The body tries really hard not to drop the glucose in the blood. If you drop it in your blood, finger stick positive, that's diabetes. So for years, it's going to do everything it can to not get diabetes. So you'll be in this insulin resistant stage for a long time. And what does it do? It creates belly fat. That's why we have this difficulty losing weight. And the reason it's around belly is because it's actually fat that's surrounding the organs, something called visceral fat, which we really don't want, fatty liver. it creates cholesterol, and that's so sometimes we'll see someone whose sugar is normal, the A1C is normal, but the cholesterol is high, their triglycerides are high. That's the body trying to compensate and kind of put it in areas. And then again, that insulin is now telling the testosterone telling the ovaries to create testosterone. So you have this kind of pre-diabetic picture going on. This high insulin, your sugars are normal, your A1C could be very, very normal, but all this havoc has this downstream effect, and one of it is hormonal, which is why it's not really a GYN problem, it's an insulin problem. And that's for most patients.
Yeah, now going back, something you mentioned about the belly fat, does that relate to kind of how the presentation of someone that comes in to your office and they have PCOS, how that presents with kind of the larger central abdominal obesity along with some of the other symptoms? Do you think that's behind that presentation?
Yes, that's why belly fat is more important. And I know fat is a trigger word, so we're literally talking about a type of tissue when we say belly fat.
Yes.
So just to clarify, and it's about proportion. It's not about necessarily overall size, and this is not a weight conversation, because I want to make sure we address that as well, because we know there's BMI is a problematic measure. So proportion is really important here, and if the body is overall thinner and then you have the central fat, that is a problem, because it is more of a dangerous fat than fat, let's say, in the legs, because it is taking your organs, and instead of it being, let's just say, 100% liver cells, now some of that liver cells is now fat. And that means your organs over time are not going to be functioning as well, which is sometimes why we see elevated liver enzymes, because the liver is struggling with this coating of fat. So to your point, yes, a lot of the presentation, people will say, I just have this belly, everything else is fine, I just have this belly. And it's really, again, back to the body's trying to compensate for all this extra glucose, and it's just creating this fat.
So putting that all together then, what do you like to use to help diagnose PCOS? Obviously, you get an ultrasound. Let's say you don't really see much there. What else are you looking at? Or are you doing insulin testing, sugar, all that kind of stuff, hormones?
So certainly, if the patients are A1C, in case for those not listening, your listeners who don't know, A1C is a measurement of diabetes. So if the A1C is already elevated, it's kind of a no-brainer. If you're anything above 5.7, along with these symptoms, you're insulin resistant. You could test for testosterone. Testosterone is often elevated or higher range of normal. But there is a test called the insulin resistance score. Here it's done by Quest. It's covered by most insurances. It's not a specialized functional medicine test. And what that does, it's actually testing exactly those things I just talked about. Instead of testing the sugar average, which is what A1C does, because remember, sugar average will only be relevant if that body's dropping that sugar and glucose, but it's not dropping it. So that A1C may not shift for you. So what they measure is, how's the cholesterol, how are the triglycerides, what's the insulin levels, and it's looking at that periphery, what's the inflammatory markers, and it's looking at that periphery, knowing that if that algorithm is high, you could be insulin resistant for a long time, and it gives you a score from 0 to 100, and the entire time your A1C could be normal. So that's a really great test to use.
Yeah, that's a good point. And a lot of people don't realize that the insulin, your body will just pump it out, and it will kind of suppress that glucose or even suppress that A1C. But now you have this high insulin that's out there doing all of these other things. So you have to take a deeper dive. And I like the insulin resistance test.
Yeah, it's a great test. And you know what, because for a lot of patients, they're like, I'm probably eating too many carbs, and they go for their annual, that A1C is normal. It makes them feel like, oh, maybe I don't need to make any changes because my A1C is good. Right. So
there's going to be a lot of doctors that are going to confirm that for them as well. Right.
Yeah, right. Yeah. 100%. I used to think A1C was an early detector when I first started. I was like, oh, A1C is great. I now know that A1C is a late marker.
Right. How much insulin is it taking for that A1C to be there?
Yeah.
Exactly. So don't rest on the A1C, guys.
Yeah. So you mentioned, so when patients come and see you, they've often maybe already had the diagnosis. They got a couple scripts, meds that they want, their doctor wants them to start. What are the medications that you see that are commonly diagnosed, and are they effective at all?
Sure. Um, so yes, the medications are going to be effective, just like blood pressure medication is effective. It's just not getting to root cause. And so, and if you are at the place in your life where medication is where you want to be, that's okay. Take them instead of not taking them. I always want to, make sure we're not telling people not to take their meds, because it really depends on where you are in your life if you can make the commitments necessary for lifestyle modification. So one, a kind of obvious one, is birth control. So you're coming into your GYN, hey, my period's irregular, I can't figure it out. Someday I skip a month, sometimes I get it twice a month. Birth control will solve that. It will make you regular. It will make you appear regular. And if you anyway need birth control, go ahead and use it. Why not, right? You need, and this is a problem for some women, because like they need the birth control anyway. But it's not actually fixing anything. It's just it's mimicking a cycle for you. And so this is important, because sometimes people will be on the pill during their, they don't want to get pregnant. And then they decide they want to get pregnant. So now they come off the pill and they can't get pregnant. And they're like, wow, it's because I was on the pill for so long. No, it's not. It's because you had PCOS to begin with. And the entire time we did not address it. Right. And so now we have to address it. I get a lot. I have a lot of patients who's like, man, I was on the pill. Now I have, I have fertility issues, endometriosis, I have another autoimmune like psoriasis, a hypothyroid. Now they're coming in because they're trying to conceive, and that becomes a problem. But the problem was already there, so the birth control masked it. The other medication is metformin, and so here's another one. We know that in the medical world that metformin is a diabetes medication, but the 34-year-old who just went to her GYN thinks metformin is a PCOS medication. She does not know. The layperson does not know. So they're thinking, again, oh, wow, I have PCOS. Here's a medication for PCOS. So I empower them like, no. This is like a baseline diabetes medication.
Yeah.
Will it work? Sure. It will make you more insulin sensitive. But of course, we could do it without that. And then there are medications like spironolactone, which helps with facial hair. Again, not getting to the root cause of why testosterone is elevated. It's bringing it down. And then there's, of course, acne medications. So the medications will work, but they're not curing anything.
Yeah. So let's get to the root cause, Dr. Crystal. And let's treat it, right? Let's see.
Yes, that's right. Do you ever see it without elevated insulin?
Yes.
Okay.
Because you might not catch it on that day, right? Insulin,
it fluctuates. Yeah.
It fluctuates.
Yeah. Right.
You might not catch it. So that is another reason why it's hard to diagnose, and you have to kind of put the constellation of symptoms together as well.
Yeah. Which is a better approach, right? Because you're looking at it more holistically. What the body's trying not to have diabetes. So how does it do that? It shoves that sugar down up fat pathways and other things, so it keeps the sugar out of the blood, right? I mean, that's the thing. So let's move on to nutrients then. So if the medications aren't treating the root cause, what does? Maybe that's a better question.
Excellent. So the goal and I want to say most, because there is for your listeners, there is a segment of the population that it's not an insulin resistant pathway that makes PCOS, and we could address that momentarily. But for the goal of 95% of the women with PCOS is to get you to be insulin sensitive. Right? We want that. We want your body to stop producing over too much insulin. We want your cells to welcome insulin back into their lives. That is the goal. The number one thing that I love, the number one tool I love to use, and it's completely free, is intermittent fasting. Right? It's completely free. In fact, it saves you money.
Right.
So intermittent fasting, at the new method, we promote something called 16-8. You eat for 8 hours. You fast for 16. For those of you panicking, oh my God, 16, it includes your sleep time, right? So just as an example, you eat from 11 to 7, and then you fast, you go to sleep, you wake up at 11. What happens during that fasting time, and it gives your body 16 hours or longer if you can handle it, to really not have to process glucose. It's as simple as that.
Mhm.
Will you lose weight? Yeah, likely, but this is not, I don't advocate this for weight
Right.
loss purposes. That's a side effect. It's really about insulin sensitivity. So for 16 hours, your body does not have to work. It does not have to process. Things calm down. Not just PCOS. There's so many other things that calm down when that happens, but things start to calm down. So intermittent fasting. And then during the day, during your 8 hours of eating, you want to try to choose low carb options. And as strict as you can handle it. I'm not saying zero carbs, and please don't come at me with that broccoli is a carb. I know people will say this all the time on TikTok. How could you say no carbs? Broccoli is a carb. I don't mean those carbs.
Yeah.
Yeah. I mean,
There's those other carbs,
Maybe
those white ones.
non-starchy.
yeah, maybe like the donuts, and like there's like there's such many like wise guys on the internet. I'm like, yes, I know vegetables are carb. Everybody knows it's not what I mean. So intermittent fasting, low carb is where you really want to start. And that could be done. It doesn't mean, for those of you out there, it doesn't mean you have to meal prep, and it doesn't mean you have to go crazy. It just means make better choices within the time frame. You'd be amazed how slow and steady small changes make a difference.
Yeah.
And then we could talk about like some supplements that help as well. Like one of the classic supplements for PCOS is inositol. Inositol is a supplement that really has been shown to improve insulin sensitivity. So why not? So if we're improving, so you see it for PCOS, but the reason you see that with PCOS is because it helps insulin sensitivity. Omega-3 is something we really want to put in there, again, because omega-3 is known to bring down testosterone levels, improve lipid profiles, which we know we have these patients with cholesterol. So we know that's something that's going to help. Vitamin D for everyone, every day, always. I don't care what's going on with
That's
you.
foundation. Yeah, that's it.
Yeah, but I mean, those are two really, I mean, there's a whole list, but get those three on point, and you're already, you're winning.
Yeah. I
And
like that.
Yeah, those are new. Any lifestyle besides, you talked about the eating. What about exercise?
Yeah. So I try not to use the word exercise. I try to say the word movement, because so many people hate exercise.
I like that.
Right. And
we had a whole conversation with Dr. Cruz. Remember that about
yes.
we've heard all of our lives. Oh, eat better and exercise. I mean, that's it.
Yeah.
What does that mean?
And I mean, I really do know people. I say the word exercise, and I see it's like a trigger word for them. It's like the whole face closes up.
That's kind of me. That's kind of me.
I'm out of here.
And that's important. It's important to know that about our patients, about our clients, because you could say exercise all day long. They are literally not hearing you. And it's not exercise, right? It's not about going to the gym. It's not about lifting weights. It's about creating movement in your actual daily life that you will do forever without a membership, without special equipment. So, and it could be also very, very small. If you're a patient that you're working virtually and you're home all the time, getting up every 2 hours for a 5 to 10 minute walk around the block is huge. Yeah. It's huge. Yeah, right. So and so for a lot of people, they feel like it's either or. Either I have the fancy outfit at the great gym or a personal trainer, or I do nothing.
Somebody I know.
I wonder
that
who.
way.
I wonder who.
Dr. Crystal.
Look, fancy outfits, I'm in.
Like I work from home. My wife works from home. So in the morning, I'll say, hey, when do you have a break at Zoom? And she'll say, 2:00. I'm like, let's go for a half-hour walk. That is huge. Midday walk. A lot of my team in the office during lunch, they take a walk.
Yeah.
And that is what we mean by movement, because that helps insulin resistance so much.
Yeah.
Wow.
This has been fantastic. So eating, not exercise, movement. There's a few supplements and stuff. And I like what you said, if somebody's in a place in their life where the meds are the best choice, and the meds are the best choice, right? I think
absolutely
we have to accept where people are at sometimes, and we can't force them into a place that they're not ready to go,
Absolutely. I'm glad you brought that up again, because a listener might be listening to this really wanting to make the changes right now. would have these meds and be like, I really want to do this, and maybe they can't. Maybe they have 3 full-time jobs. They're going through a divorce. Like life is just complicated. And so they might be either debating whether to take the meds or in the place of a lot of negative self-talk. Don't do that. Keep listening to these type of podcasts. Eventually the space will come for you in your life where you can do it. But in the meantime, keep yourself safe and take the medications that you need, whether it's this or another issue. And you can come back to this. This is not going anywhere.
Yeah. I love that. That to me is what I really like about just integrative medicine, in how, you maybe you need the meds now, so go for it, take it. But when you start implementing some of these lifestyle changes, the dietary changes, maybe you need a little less of that med down the line, or maybe eventually you don't need it at all. And so it's a journey. It's not like it has to be like right now,
100%.
Right.
It's a journey.
I like that. What would you like to say to our listening audience, just as kind of like the final thought?
I really want to tell everyone that in line of what you just said, it's small, steady steps. In fact, if you try to do it all at once, go intermittent fasting, you have the smoothie, walk 20 times a day, do all these things, you're more likely to not succeed. Yeah. But if you take small steps that become part of your routine, that 5-minute walk, over time, you'll be surprised that you're doing a half-hour walk. Because I know that about myself. I was, as an asthmatic, I couldn't run. I just started running 1 block, and over time it became 3 miles. But slow, steady, small, celebrate the wins, and a year from now, you won't even believe how far you've come.
Yeah, that's great. That's great. You're listening to Dr. Efrat LaMandre, or Dr. E. How can somebody get a hold of you? Where can they learn more about you?
So the company's called The New Method, and new is spelled with a K because you guys always know there's a better way. So everyone knows. So The New Method everywhere: Instagram, TikTok, YouTube, and even Threads.
Gotcha. Oh, you're on look at that. You're up to date. Yeah.
I'm up to date.
That's awesome. So Dr. E, thank you so much for coming on today. Don't forget, you can go to liveforeverish.com, where there's a lot of other podcasts that you can download, like, and share. And of course, don't forget to subscribe so you never miss a show. And our sponsor, Life Extension, because you guys are such a great audience, is offering you 10% off your entire order at lifeextension.com. So when you check out, just put in the discount code podcast and get your 10% off. Again, this is all at liveforeverish.com. I'm Dr. Mike. Thanks for listening.